All right, let's get into some of the pathophysiology, and we're going to talk about immunodeficiency disorders. So in today's lecture, I'm going to break it down into four categories of the primary immunodeficiency disorders. We've got the cellular immunodeficiencies, the T-cell immunodeficiencies, the B-cell and antibody immunodeficiencies, and finally, innate immune disorders. Okay? With the cellular immunodeficiencies, we're going to talk about DiGeorge syndrome, severe combined immunodeficiency, chronic mucocutaneous candidiasis. For the T-cell immunodeficiencies, we're going to talk about ataxia, telangiectasia, Wiskott-Aldrich syndrome. And then our B-cell and antibody immunodeficiencies, we're going to talk about Bruton, X-linked agammaglobulinemia, common variable immunodeficiencies, and hyper-IgM immunodeficiency. And then finally, our last category is the innate immune disorders, where we will discuss hyper-IgE syndrome. DiGeorge syndrome is a congenital T-cell defect. There is actually lost genetic material on chromosome number 22. This can be referred to also as a congenital thymic hypoplasia, and newborns may have pharyngeal pouch syndrome, which is facial and vascular abnormalities. Okay? The development defect happens in the embryo, and it causes the absence of the thymus and parathyroid glands, or a malformation of the heart and blood vessels. Infants have low calcium levels, and this is called hypokalemia. In this disease, T cells are low and B cells are present, but antibody production is limited due to a decrease in the number of T cells. The patients here are prone to several infections, including acid-fast bacillus infections, listeria, pneumocystis. They have diarrhea or failure to thrive, and it can be corrected with a fetal thymus transplant. This can actually restore T-cell activity, but other deformities are an independent problem. Severe combined immunodeficiency is an autosomal recessive and X-linked recessive trait. Some signs and symptoms of severe combined immunodeficiency would be life-threatening infections beginning at about 6 months of age. This can be treated with a bone marrow transplant, but is usually deadly by the age of 3. Patients present with lymphocytopenia and a low T-cell function, but the percentage of B cells is actually normal. Chronic mucocutaneous candidiasis is a T-cell defect. The T cells don't recognize Candida antigen, and these patients can present with thrush. They also have fungal infections of the scalp, skin, and nails, and it is deadly from an adrenal insufficiency. It can be treatable with anti-candida, but infections will continue to occur if treatment stops. These folks also have endocrine issues, including hyperthyroidism and Addison's disease. Their T cells respond normally to other antigens, and their B cells are unaffected, but they are prone to skin and mucosal surfaces infections from Candida albicans. Ataxia telangiectasia is a disturbance of gait and posture. Ataxia means loss of muscle coordination, and telangiectasia means a dilation of the small blood vessels. People that have ataxia telangiectasia have superficial abnormalities of the blood vessel, and IgA in the secretory component is abnormal. This is an autosomal recessive disorder, and these folks are at risk for severe respiratory issues. They may receive injections of IgG to help them with this disease. It is a neurodegenerative inherited disease where the lymphocytes are decreased, IgM is increased, and IgE is decreased. These folks have chronic respiratory infections associated with this deficiency, and it could be a T-cell deficiency with a defect in DNA repair. Wiskott-Aldrich syndrome is an X-linked genetic disorder. It affects male infants, and it is usually fatal by the age of 10. These patients have increased bleeding due to low platelets or thrombocytopenia. It is a bleeding disease from small and dysfunctional platelets. Okay? They have an inability to respond to polysaccharide antigens, so they can't respond immunologically to bacterial antigens. They have increased infections, both bacterial and viral. Their IgM levels are low, but their IgG is normal or increased. They cannot make antibodies to vaccines, and most develop an autoimmune disease and malignancies. Here in this disease, their IgA and IgE levels are increased, and their IgM is decreased. A specific type of agammaglobulinemia is Bruton's X-linked agammaglobulinemia. This is a congenital disease that usually goes from mother to male children, although once in a while it is transmitted from mother to female children, but this is quite rare. It's almost always seen in males, and it's usually apparent at about 6 months of age. These folks generally have multiple bacterial infections, including Haemophilus infections, Neisseria infections, and respiratory infections from pneumocystis. Their T cells appear to be okay, but their B cell populations are absent in the bone marrow and lymphoid tissues. And then the B cells that they do have, which are very few, never mature in these patients. Patients are not overly susceptible to viral infections, but usually are susceptible to bacterial infections. Okay, they can actually treat this type of agammaglobulinemia with a shot of IgG every 3 to 4 weeks of life. We cannot measure their antibodies in serology tests for viral diseases because they don't make antibodies. Hyper-IgM immunodeficiency is an X chromosome mutation that occurs in the first or second year of life. Here they have increased IgM levels, they have decreased IgG and decreased IgA levels, they're extremely low, and they have recurrent infections including otitis media, which is an ear infection, sinusitis, pneumonia, and tonsillitis. These folks have recurrent neutropenia, hemolytic anemias, and aplastic anemia, which is a bone marrow disorder that causes low red cell production. Patients often die before puberty from opportunistic infections or B-cell lymphomas. Hyper-IgE syndrome is also known as Job syndrome. This is an autosomal dominant pattern. It can be corrected with a bone marrow transplant or IgG replacement therapy. Usually people that have hyper-IgE syndrome have recurrent staphylococcal abscesses.